tumors are rare. As Dr. Santosh was just mentioning, a general orthopedic practitioner, a busy general orthopedic practitioner like Dr. Santosh himself, will see a one-off malignancy in maybe 6 months or 1 year, and a few benign bone tumors besides that. This being rare, people, the general public or the laymen sometimes do not even know that tumors or cancers can happen in bones. Similarly, the centers which are catering to bone cancer or malignant bone tumors are also rare. So when things are rare, they are coming they are being seen by a particular physician or an orthopedician only once in a while. The chances of mistakes happening are high. And the cost of these mistakes are also going to be high because primary bone malignancies like osteosarcoma have a high mortality and also a high morbidity in terms of loss of both limbs and lives if not treated well in time. So that is why we are discussing the 10 common mistakes that a general orthopedic surgeon or a non-oncology orthopedic surgeon could make when he deals with a bone tumor. Mind you, the orthopedic surgeon of a particular family is a very, very important part of the whole chain of quick referral and timely treatment of a patient with a bone cancer. And this is where this important role comes in, when you know what are the mistakes that you could do and you must avoid. The first mistake that comes to my mind and we keep seeing is a presumption of diagnosis. Quite often we see that a diagnosis of, especially like in our country, tuberculosis is presumed. We all know that tuberculosis is still quite common and endemic in India, and skeletal tuberculosis is no exception. But mind you, not all bony lesions are tuberculosis. And as soon as you think about presuming a diagnosis of TB and starting empirical ATT, you must have a word of caution. Just discuss with yourself or the radiologist and anyone who you think is an expert as to whether this could be something other than TB. I think the days of empirical ATT in the absence of unequivocal diagnosis are gone, because we keep seeing disasters happening just because TB ATT was started and continued for some time to see the effect, and precious time is lost in these patients who were actually not TB but a malignancy. So presume nothing will be my first message. And we can see this sacral mass was treated with anti-tubercular treatment for about 9 months. Obviously, there was no improvement, and this is the kind of progression that the patient had. And a biopsy, all it would have taken was a core needle biopsy, which would have proved this was actually a giant cell tumor and not tuberculosis. Another patient who had a spinal lesion was treated on ATT, and there was worsening of neurological symptoms as the patient continued having anti-tubercular treatment. All it again needed was a core needle biopsy, and it came out to be an osteoblastoma. So what this patient needed was surgery and not ATT. Another patient, a lytic lesion in the vicinity of the acetabulum or the periarticular area, was again treated with anti-tubercular treatment for 3 months. What it actually was a pigmented villonodular synovitis, again leading to progression of disease while the patient was having anti-tubercular treatment. So once you know that you do not have to presume a diagnosis, always try and establish your diagnosis, even if you want to start anti-tubercular treatment or you want to go in and do a definitive surgery. The second common cardinal mistake that we see people doing is combining biopsy with fixation. So we all know, as orthopedicians, we are all skilled in fixing fractures. And any patient who has had a fracture of, say, a femoral shaft, obviously is going to need fixation. Why not do the fixation and a biopsy in the same time? It is logistically easy, give the patient comfort earlier, and then we can start thinking about definitive management later on. This is a common mistake or a common wrongly placed notion that orthopedicians might have. We should not combine fix or biopsy with fixation. A lot of times a biopsy will come out where you are not supposed to fix. For example, a sarcoma of a bone with a fracture does not require fixation. And I'll show you some examples. So this patient had a lytic lesion and a fracture. The surgeon, in all good faith, decided that it will be good for the patient that I biopsy this area and at the same time fix. It will save the patient 2 procedures and the definitive management can follow. Unfortunately, it came out to be a chondrosarcoma. And now we know that even if the fracture was fixed, the reaming and the nail caused a contamination of the whole femoral shaft. So what was to be a proximal femoral resection ultimately had to be converted into a total femur replacement. And this is how the malignancy was only till this area, but we had to remove the whole femur because the whole femur was contaminated by the reamers and the nails. So this is what happened. This is how you had to remove the whole bone. So this is what happens when we combine fixation with biopsy. We must avoid doing that. We must establish a diagnosis, sometimes without a biopsy. Sometimes you might have enough evidence that the patient has a primary cancer with a secondary malignancy in the femur, and then you can go ahead and fix. But all primary malignancies, even if there is the slightest doubt, we must do a small biopsy, establish the diagnosis, and then think about fixation. The next common mistake that we have seen is going solo. Of course, we as surgeons are used to taking big decisions, bold decisions, and of course, they are all in the interest of the patient. But orthopedic oncology is one area where you will not want to go solo. It is all about multidisciplinary treatment. And even we who are doing exclusive orthopedic oncology work never go solo. And I'll show you how. This patient had, I'm not sure if you can see, but there is a periosteal reaction with some lesion here in the distal tibia. A small needle biopsy was done, and the outcome was overall features being suggestive of periosteal osteosarcoma. The pathologist was quite right in also writing down that, however, a radiological input should be obtained. Now, an osteosarcoma, as we know, would have meant a big surgery. But the moment a musculoskeletal radiologist sees this patient, the whole diagnosis changes. We know that new bone formation out of even a sprain or a stress fracture can look like osteosarcoma to the pathologist. What he needs to be supplied with is a good radiological input. And we can see the radiographs after they were evaluated by a musculoskeletal radiologist actually showed that it was just an ankle sprain with an ossification around the interosseous membrane. So all this patient needed was a radiological evaluation and then just observation and no surgery. So this is the difference that comes when we decide not to go solo and have all experts on board. Another example, we can see this was a myeloma with a huge lytic lesion of the tibia, of course, with a pathological fracture. Now, knowing this is myeloma, and an orthopedic surgeon knows that he has to fix this fracture after the diagnosis is established, not before that. But if he talks to his medical oncologist, he will know the effect of adjuvant treatment is going to be very good in myeloma. And that was exactly what happened. And we can see very good ossification after chemo and radiotherapy for this patient. So this is the difference that a multidisciplinary discussion and approach brings. This patient, instead of being subjected to a big surgery, all she needed was intramedullary fixation, and what follows can be seen. Another similar patient with a diaphyseal lytic lesion of the humerus. Now, this was renal cell carcinoma. Again, if you talk to your radiation oncologist or medical oncologist, they would tell you that renal cell carcinoma is not very sensitive to radiation. So now here, you know that probably just fixing the fracture will not work. And it is here that you would not want to just fix, but also curate and cement. So this is how you decide whether you want to just fix or you want to cement as well. Another example of myeloma, and you can see a badly involved femur. All we did was to just precariously place her implant, and knowing this is myeloma, just healed very well. And it's not just the orthopedic oncologist who goes ahead. It is a whole team that is involved. And we can see here our pediatric oncologist, he's a sarcoma medical oncologist, a radiation oncologist, palliative care, psycho-oncologist, physiotherapy. And the pathologists and the radiologists are exclusive musculoskeletal pathology and radiology people. So this is the kind of team that you should look forward to having. And even if you don't have access to such a team, you'll always have friends whom you can, depend upon. So that was about not going solo. So you must avoid going solo and have opinions before you go ahead. It may make a huge difference in the patient's outcome. The next common mistake that we might sometimes commit is having a major decision which is based on just an FNAC report. A fine needle aspiration cytology has practically no place in the primary treatment or tumor. We must remember that for a primary diagnosis, we must have a biopsy, and an FNAC is just not good enough. I'll show you a couple of examples. This patient had a mass just next to the humerus, and we can see it's quite a sizable mass. Obviously, the patient and the referring orthopedician were quite concerned. An FNAC was done, and this was reported as a spindle cell lesion. The patient, on the basis of this FNAC, was advised a wide excision with sacrifice of axillary nerve because this looked like a soft tissue sarcoma. You must remember that FNAC shows just the few cells that you can aspirate. It does not show the matrix well. It does not show how the cells are interacting with each other. So it does not give the pathologist the full information. And especially in centers where bone tumors are not very commonly seen, this is even more likely to make a mistake. So this advice was what the patient came to us with. True cut biopsy instead of an FNAC. This lesion actually came out to be myositis ossificans. Everything changed. The patient was advised just observation. In case the patient still wants excision of that bony mass, because with observation that just ossifies and stays there, it would be a late excision and obviously sparing the axillary nerve and shoulder function. So this patient was spared from loss of function, and he was also spared from surgery in the active phase of myositis, which would have meant a certain recurrence. Another good example, we can see here that this young man had a proximal tibial lesion. It is an epiphyseal lesion, and we all know, and we have been taught in even a residency, that epiphyseal eccentric lesions are giant cell tumors most commonly. But if we carefully see, there is also a certain soft tissue component. The margins are not that well defined. And the next webinar, I must remind, is going to be on X-ray, how to read an X-ray and rule out a malignancy. So we can see the margins are not that well defined, and there's a soft tissue component. There might be also a hint of osteoid or ossification happening here. So this certainly is not a typical giant cell tumor. And that's the MRI, and MRI confirms that there is a soft tissue. An FNAC was done, and it came out as a giant cell rich lesion. And this example again underlines the teaching that FNAC should not be used to take major decisions. The surgeon, in all good faith, went ahead and did a curettage for a so-called giant cell tumor. And lo and behold, the ultimate diagnosis was a giant cell rich osteosarcoma. The outcome of FNAC was not wrong, but basing a major surgery just on the FNAC was wrong. And that is what led to this patient. So this is the final histopathology showing giant Dulwich osteosarcoma, and the patient had to undergo one more surgery. The fifth common mistake that we see is operating on touch me not lesions. So we again as orthopedicians have this temptation to just go in and curate anything, any bony lesion that comes our way. We can always fill it up with bone graft, fix it, and then see what happens. A lot of lesions, mind you, do not require surgery at all. And in today's times, it is our duty to know what these lesions are. The list is quite long. In fact, non-ossifying fibromas, fibrocortical defects, a lot of fibrous dysplasias will not require surgery. And that is something that we should remember. One good example, this 60 plus lady had, an X-ray done for osteoarthritis of knee. And the radiologist noticed something happening here. We can see it's a popcorn type of a calcification with some lytic areas in the metaphysis. It's not a very big size. It's not scalloping the endosteum. There is no cortical involvement, no soft tissue component. Most likely this was a chondroid or cartilaginous lesion. The orthopedic surgeon in all good faith went ahead and did a curettage. Fine curettage was done. Specimen was sent for histopathology. The histopathology came out as enchondroma, which is a benign cartilaginous lesion, and the patient unfortunately sustained a fracture. Enchondromas do not require any surgery. And if there was the slightest notion that this was an enchondroma and it doesn't require surgery, the surgeon would not have operated at all. So this became not one but two surgeries, both of which were uncalled for. The patient required neither a curettage nor this fixation. So that is what happens when we try and touch these touch me not lesions. Another example, this 13-year-old boy was referred for a fibrous dysplasia of the tibia. Knowing that these lesions will ultimately ossify and consolidate, the temptation to go ahead and curate should be resisted. And all we need to do was just put the patient on bisphosphonate therapy, and we can see as the patient neared skeletal maturity, the lesion had ossified. The sixth common mistake is combining a definitive surgery with biopsy. Oftentimes we think that this patient is anyways going to need a curettage or some removal of this tumor. Why not combine this definitive surgery with biopsy? Again, logic says that you will avoid two anesthesias, you will bring down the cost, but quite often it has been seen that the definitive surgery which was planned was not appropriate for the biopsy that comes out after this surgery. So it is imperative that we remember that we must biopsy and then wait for the report and go ahead for definitive surgery later on. Of course, this does not apply to lesions which are very, very clearly diagnosable just on radiology. One example is an osteochondroma, where any radiologist will be able to tell you with all confidence that this is an osteochondroma. So this is one rare instance where you go ahead with surgery without biopsy. Otherwise, biopsy and definitive surgeries should not be combined. They are two separate procedures. And we all are now proponents of needle biopsies. Biopsy is not anymore an open procedure. 90 or 95% of patients can be diagnosed just on a core needle biopsy, quite often just in the OPD. So always biopsy, wait for the report, and then go ahead with definitive treatment. For example, this 17-year-old boy, a common approach has been for on spinal lesions to just go in and do an anterolateral decompression and see whether it's a tumor or tuberculosis. If it's tuberculosis, start ATT. If it's tumor, send for chemoradiotherapy. But this approach is not good. And let us see how. This 17-year-old boy was diagnosed diagnosed on a true cut biopsy, and the histopathology was chondroblastic osteosarcoma. Thankfully, we did the biopsy, and then this patient could undergo a wide excision. And this patient is alive and disease-free 8 years post-op. A very similar patient, again a 19-year-old boy, and mind you, both these patients were from Nepal. This patient again had a mass, and this presented to a non-oncology center, and a piecemeal excision and subsequent histopathological examination were planned. This patient came out to have a chondrosarcoma, and this patient then was referred to an oncology center, but it was too late, and the patient could not be subjected to a wide margin surgery like the previous patient. This patient ultimately had local progression and died of disease. So this is how the two approaches in a very similar patients can lead to two entirely different outcomes. One more example. This patient was from Northeast, and he was having a lytic lesion here. The orthopedic surgeon, in all good faith, decided to just fix what the problem that was happening mechanically and also do the biopsy at the same time. He curated it, cemented, and nailed at the same time and sent the material for histopathology. And what came out was an osteosarcoma. Obviously, this surgery was not enough for osteosarcoma. And at the same time, there was contamination all around. We can see the recurrent mass, and the whole femur was now contaminated. This patient had to undergo a hip disarticulation for a sarcoma that was there in the distal femur. This lesion otherwise was very much amenable to a limb saving surgery. Another mistake is to do a biopsy without following principles. There cannot be enough emphasis on the need for a biopsy with correct principles being followed. The placement of biopsy, and this all was discussed in the last webinar, but this is being repeated here for the fact that it's so important. We must ask ourselves whether we are the right person to biopsy this patient. If you think the patient has got a bone cancer, you might want to ask yourself whether you are the right person to biopsy, or you want to send this patient to an oncology center. We must not biopsy if we are not sure of this answer. We know that biopsy has to be placed in line with the ultimate limb salvage surgery incision, because the biopsy, having been seeded with tumor cells, has to go away with wide margins along with the specimen. Let us see what an improperly placed biopsy can do. This patient had a biopsy from a gluteal mass, which was actually an osteosarcoma of the iliac bone. It was done through the gluteus maximus. Because there was then progression, he had to undergo an anterior flap hemipelvectomy with a loss of the limb. A very similar patient who presented to an oncology center, where a biopsy was done not through the gluteal muscle, but a needle biopsy along the iliac crest, because we know the incision of limb salvage surgery is going to be here. The result and the outcome was a limb salvage surgery. And this was the ultimate surgery that was a type 1+2 hemipelvectomy, and the outcome was that the patient could easily walk. So two very similar patients, biopsied differently and having different outcomes. More mistakes that quite often are done are placing a drain far away, placing your suture bites quite wide, because all the skin is going to be contaminated with tumor and will need excision later on. Another mistake is to traverse multiple compartments. So this biopsy was accompanied by violating more than one compartment, and this is what further complicates limb salvage surgery. One more mistake is to have multiple scars. If you have had a patient where one scar was used, if you keep placing more scars just for biopsy, you know that all these areas are going to get contaminated with tumor, and these patients can not be subjected to limb salvage surgery later on. The eighth and another very important mistake that we have to avoid is the practice of dividing tissue amongst two labs. It has been quite a common practice to just send whatever tissue you have taken to two labs so that you can have two different opinions. This practice is not good, because sarcomas are not heterogeneous, not homogeneous. They are all heterogeneous. Many bone tumors, particularly malignancies, will have heterogeneous areas. And let us see an example. This patient had undergone a biopsy from the distal femoral mass, and we can see the sections from tumoral mass show variable morphology. Focal conventional giant cell tumors which look benign to areas which were actually malignant. And this could actually be shown. These are the conventional GCT areas within the same lesion, and the same lesion had a pleomorphic sarcoma area. So now imagine if you had sent two different labs, this material to two different labs. You could have sent the benign one to one lab and the malignant one to the other. And then which one do you follow? Sometimes the whole material gives a lot more information. If at all you have to have a second opinion, you must get everything checked at a good lab, preferably with experience in bone and soft tissue pathology. And then you can get those blocks out and have them rechecked by another pathologist that you have confidence in. Another mistake that sometimes is seen is a forecast of a poor prognosis without solid reason. Friends, like all branches in medicine and all branches in orthopedics, oncology also is undergoing vast changes. The prognosis of many patients are now changing, and we might not be wrong, we might not be right in telling the family or the patient that your days are now numbered. A patient having a bone sarcoma, a particular orthopedic surgeon may not have had the chance to look to see a long-term survivor. But we now know that non-metastatic osteosarcomas has a 65 to 70% cure rate. Similarly, patients with other malignancies are now surviving more and more. So just to tell a patient that your days are numbered without being aware of whatever advances have happened may not be the best thing to do. Let's look at an example. This patient had a proximal femoral lesion, and the workup showed this was a cancer thyroid. A cancer of thyroid with a metastasis. She was told that her days are now numbered. But actually we know that complete excision of the solitary metastasis and of the thyroid can actually have a long-term survivor. And this is what this patient ultimately had. This patient was from Bihar, and he was told, because he had multiple skeletal lesions, he was told that he has got disseminated malignancy and his days are now numbered. He came running to Delhi and reached our center. This patient ultimately, all we had to do was to do a biopsy and see what he had. And he had a multifocal hemangioendothelioma, which has a good long-term outcome in case it is borderline malignant. This patient underwent multiple excisions and some radiotherapy, and the patient is still doing well 8 years on. And he keeps asking the primary physicians who saw him first, why did you tell me that I have a bad prognosis and I'm not going to live long? Another example, this was a 10-year-old boy back in 2012, and he had Ewing sarcoma of the proximal tibia. He also, on the metastatic workup, showed pulmonary nodules. So this was actually stage 4 disease. But we now know that Ewing sarcoma with metastasis only to the lungs, it's not as if there are going to be a 0% cure. This patient fell under the 30 to 40% long-term survivors, even with lung metastasis with Ewing sarcoma. With chemotherapy, all the lung nodules disappeared, and this is what we did. We excised, unblock, and sent the specimen for radiotherapy during surgery, and reimplanted the radiated specimen back. There was good healing, and this is how the child behaved. This is 3 years post-op, and we can see the child is at least 3 years survivor. And now he came to me about a few months back, and he's now 8 years post-op. So, and a boy having Ewing sarcoma with pulmonary metastasis, doing well 8 years post-surgery, and God willing, he'll do now well, and he's probably cured of Ewing sarcoma. So this is what is now happening. The survival rates are increasing, not just of bone cancer, but all other cancers. And we may not always be aware of what all has happened during the past few years. And this we should remember before telling a patient that your prognosis is not good. The best is to refer these patients to an oncology center for all counseling. The 10th common mistake is a delay in referral. Sometimes we remain confused. Sometimes we may not have access to a referring channel. Sometimes our patients may not be having the resources to reach the right place. But it's our duty to emphasize and re-emphasize and probably track them and tell them that please go to an oncology center before it is too late. As I said in the beginning, orthopedic surgeon, the family orthopedic surgeon is the first point of contact for most patients with sarcoma. And it is our duty that we ensure an early referral to a specialized center, because that is what will make all the difference. And this, I think, is the single most important contribution of an orthopedic surgeon as far as cancers of bone are concerned. So just to repeat the 10 common mistakes: avoid presumptive diagnosis, avoid combining biopsy with fixation of a fracture, avoid a delay in referral, avoid taking major decisions based on just fine needle aspiration cytology, avoid wrongly done biopsies and follow all principles of biopsy. In fact, even ask yourself whether you should be doing this biopsy or someone else. Avoid giving a poor forecast or a poor prognosis without solid reason. Avoid combining a definitive surgery with a biopsy in a suspected patient with bone cancer. Avoid dividing tissue amongst two labs. Avoid going solo. Have opinions from experts before you take any big decision. And avoid operating on lesions which have to be left alone and which are touch me not. I guess that is all, and thank you all for giving me your attention and time, and I am open to any more questions.
Thank you, Dr. Akshay, for giving a nice presentation to our delegates about what are the common
Dr. Santosh, please unmute.
Yeah, I am unmute. I'm unmute. I'm not
there.
Yeah. So thank you, Dr. Akshay, for giving a nice point-wise, accurately defined what not to do. The main thing is when we're dealing like these cases, because exactly your first slide is very rare for us. And if we do the biopsy of these cases, it will again, when we send to any pathologist, and his or her experience is very low among the tumors. So it is very difficult sometimes what the diagnosis is rightly about the case. And sometimes we are not selecting the appropriate case and wrongly diagnosed as it is a tubercular and give them 3 weeks ATT and let's see what happened to them. This is a common practice in the cases of the general orthopedic surgeon. So first of all, my concern is when we have a great suspicion among the tumors. So you have any tips regarding this? So when we have to do the biopsy or when we have to do the referring the case, because the patient also wants, why we go there? Can this not happen to be here? The treatment or diagnosis cannot be made here. Why we go there? And by hearing the higher center's name and cancer institute, he's afraid of that one. So can you give some very lazy tips about the suspicion and biopsy to be taken? Dr.
Yeah.
Akshay.
Very nice question, and I think this is a very, very practical situation that each one of us finds themselves in. And the more peripheral the area of practice of the orthopedic surgeon, the more important this problem becomes. Quite often the patient, in fact, does not have the wherewithal or the resources to reach a center. And you find yourself in a moral dilemma as to help that patient or refer him. I think in today's times, telemedicine has come in a big way. Each one of us will have friends in some center or the other, and we can always ask for opinions based on clinical picture and radiology. We can all have, in fact, we are now having pan-India tumor boards by National Cancer Grid. And in fact, Max Hospital, our own center, hosts these tumor boards every 8th Wednesday. So that is where you can officially put your case and have an official opinion as to how to go about it. Short of that, you can always have an informal opinion from someone who is in the field of oncology. He will be able to guide you whether you should biopsy or just not touch that patient. A patient who is a benign tumor, sometimes which may not need any treatment, you will get an opinion that please just observe and do nothing. Sometimes you will get the opinion that this patient probably has a malignancy and probably be very sure before going ahead for biopsy. Or he might know some center in the vicinity of that patient where that biopsy will be adequately done. So all this, I think telemedicine is something that we must use liberally now. And we anyways keep taking each other's opinions through WhatsApp groups or through personal communications. And that is what I think should be the basis. I think if you are not dealing with malignancies, you should avoid doing a biopsy in the first place for a frankly malignant bone tumor. If it's a borderline or a benign thing, you can always have an opinion and see how to go about it. I think you should also have, you should also identify one center in the vicinity of your practice where you can send these patients, have opinions, and they can always come back to you after having had that opinion. I think that should answer your question.
Yes, you are right about this. So I request to other delegate, is there any question? You can unmute yourself and ask to Dr. Akshay. Or you have any query other than this regarding the oncology, or you have any case to discuss, you can put the case here.
Dr. Chabra has kindly asked a very important question. Sometimes the patient wants to take the specimen to a lab where the opinion may not be authentic. What to do then?
Yeah, nice question.
So I think our duty is to just let them know that this may not be the best place. You can probably, tell the patient this with confidence and with some emphasis, and then it is the patient's call. I think if we have sincerity in our communication, the patient will understand. But I agree that this is sometimes becomes a practical problem. I think the local orthopedic groups should have a pathology center and a radiology center identified where everyone knows that this is the center in my area where a good pathology opinion can be sought. And that is what will help both the patient and the doctors. But I guess, yes, the confidence in a pathology lab is very important. Bone tumors are very rare. A pathologist who is easily able to diagnose lung cancer may not be that confident for bone cancer.
Yes.
Sometimes bone tumors and benign bone tumors and malignancies are so similar that everything depends on radiology and pathology. And we have to have the jigsaw completed between clinico-radiopathological to come at a diagnosis. It's not as if just the pathologist will be able to give you the diagnosis in all the cases. So that is something that should be remembered.
So we should have a dedicated pathologist and dedicated radiologist for the orthopedic oncology in our vicinity.
Yes, that is very important.
Yeah.
In fact, it is the duty of all big centers to have someone get trained and come back from some big center. Why can they not do it? A big center will have 6 radiologists. One of them can say, yes, I'll do the musculoskeletal radiology part. And I think as you increase the focus, your volume goes on increasing and everybody is helped.
Yes. Doctor,
can I come in?
Ashish sir, welcome. Yeah, Dr. Sethi, please.
Yeah, that's right. I mean, wonderful talk, Akshay. Really delighted to hear everything what you mentioned is so good and right. I think the important thing what you started was people sometimes don't differentiate between primary and secondary. That's the first thing they should do. And you rightly said, they start putting implants in primary. Secondary, yes, you can put implant, but you need to know where the primary is there as well. The first thing people may come up with just a symptom as a secondary, but you don't know where the primary is. So you can even do a simple thing just by doing a CT thorax and abdomen. We're not sure about it. It's very likely, even before the biopsy, you may get an answer that the primary was there and this is a secondary lesion. And that will probably help you to plan it. And then, you can fix it if it's a secondary, and the remix could be sent for biopsy as well. So a lot of answer you can get if your first problem was a secondary lesion, knowingly where the primary was. So a lot of time you will get an answer from CT thorax and abdomen. And I rightly said, you need to have a biopsy before you do something. Not only that, a very good example is told about the enchondroma of the lady with the osteoarthritis. It's very common. I don't think so uncommon. You do see, we call as bone infarcts. These are basically benign lesion, and for no reason this patient had a surgery. So she comes for an X-ray of the knee and it's picked up. And this thing, if they had discussed with people like you would have categorically said probably no. And also, I'm sure this patient, if you palpated the distal femur, she wouldn't have any pain. Yet they can become malignant. If they become painful, they can become malignant. You can warn the patient. It's nothing to worry about. But operating on the bone infarct was a disaster, isn't it? Just sending an X-ray to a colleague who is good at seeing, who is routinely doing it, probably would have saved a lot of things. And the other thing was renal cell carcinoma you talked about, And not only that, sometimes renal cell carcinoma, you just cannot operate. You might have to embolize them because they're so vascular. Don't jump into operating them, especially around the thigh, There's a renal cell carcinoma of the femur. You know the diagnosis. It's very important to be in touch with the radiologist to see whether they can do a contrast, MR, to make sure if there's increased vascularity, you need to embolize them. Otherwise, they'll bleed to death on the table. So the renal cell carcinoma, so it's so important. I don't think general orthopedic surgeons should jump on doing these cases. The help is important. And you rightly said, sometimes the cost comes in the way. People are so far. But at least if you're taking a biopsy, the oncology can say, take a biopsy from this because maybe this patient needs a radiotherapy. The scar may not come in the way. So it's so vital in the present day scenario that we need to, even if you think benign, there's no harm in talking to, to the oncology. But Akshay, you said rightly, in a place like Lucknow, for example, somebody can take a lead and say, okay, I need to go to places like Max or Mumbai and spend about 2 months, 6 weeks, and then he will be really gained. You need a musculoskeletal oncology rather than just a sarcoma. Because I remember over here, if you've got a soft tissue, we don't send to Birmingham, we send to Leeds. If it's a bony sarcoma, we send to Birmingham. So people have specialized themselves. And I think you've rightly said, we should not jump into, these are difficult problems because we don't see them so often. I think you've spoken very well. Thanks for it.
Yeah, thanks a lot, sir. And I guess metastatic bone disease again is a huge area. And this is also one area where any orthopedic surgeon might do well as long as he's aware that it's metastatic bone disease and not a primary. That is where comes the importance of knowing the difference. I guess, Dr. Santosh, we can also have a webinar on how to manage metastatic bone disease, because a lot of points that were just raised by Dr. Sethi are very important. Which are the lesions which is fixed? Which are the lesions which have to resect? Where we have to do an arthroplasty and where we can get away with the fixation. So all this depends on a lot of things and just what the X-ray showed you. I think very, very well put, Dr. Sethi.
Dr. Praveen wants to ask a query from Bareilly. Dr. Praveen Maheshwari from Bareilly.
Boss, I have a patient who's around 25 years old. Actually, he's my hospital's driver and he's been diagnosed with osteosarcoma lower end femur. It's biopsy proved.
Okay.
Hello?
Yeah, I'm listening.
Yeah. And actually, I don't have an MRI at present with him, so I just want to discuss on his clinical conditions. He just had pain for last 2 months only. There's no history of fever or any injury or nothing, and it is a biopsy proved osteosarcoma. But he doesn't have the cartilage is spared. It is okay. So I cannot fix it with any implant. So my question is it possible to just resect and just do curettage? I have done for this adjuvant therapy. He is under the care of oncologist at present, and 1 cycle of chemotherapy has been given for osteosarcoma. Second is due after 21 days. So, and according to oncologist, 3 cycles of radiotherapy are to be given, and then we can go for surgery. My concern is just curettage and filling it with bone graft or doing some, with chemical cauterization. Or is it sufficient? Because I cannot fix it.
So is there a fracture?
No, there is no fracture.
Yeah, so a fixation or a curettage is an absolute no for osteosarcoma. And
Okay.
I will see if I can show you a couple of slides on how a bone tumor can be operated in different ways.
Yeah.
Because see, an osteosarcoma needs a resection with wide margins. And I don't think if you have not had an exposure or a training in this, that you should be doing it, because it's hard to imagine someone doing a wide resection and an implant for an osteosarcoma just as a one-off case. We should absolutely refrain from any fixation, no curettage for this patient. What he needs is a complete excision of the distal femur and reconstruction with the mega prosthesis. That what he need. Sometimes
Exactly.
the patient is not suitable for a prosthesis, even an arthrodesis can be offered.
Okay, fine. That's fine. Actually, the upper end of the tibia, and then you just remove the upper end of the tibia, manipulate it, and put it on the opposite way.
Yeah, so that
So many ways of arthrodesing any joint.
correct. So all that been done, only the basic principle that must never be violated is a wide excision without opening up the tumor or even seeing the tumor during surgery. It has to be excised with a cuff of normal tissue all around, and that is the basic that you have to follow in surgery for a malignancy.
Perfect. I'll just ask you to display your mobile number somewhere here only, so that if suppose we need you any expertise from guidance from you, or to refer the patient to your site, I can have your contact number.
Yeah, whichever. I'll put it on the chat and
You do that.
Dr. Parmain, with no offense, don't touch this patient.
Exactly. That's
Don't
why.
touch it. I'll tell you, don't touch it. You'll burn your fingers, and
I
this
understand.
patient will come back and bite you. So
Exactly.
my advice is, these are difficult. I mean, I don't think even I've done anything like that. So if you don't do, and then, in your own setup, you may have a limited resources, the vascularity, the neurology. I think it needs a mega prosthesis, resection, wide resection, replacement. It's not something we can do even in Lucknow. It has to go to a place of expertise. So I think, it's nice to have his number, be in touch with him. So keep away, you'll be a very happy man if you leave this patient.
Exactly.
Yeah.
Definitely. Thank you very much.
Anyone else, please? Dr. Akshay, anything you want more, or I think nobody has to be asked any question?
Yeah, so I guess that's it for today.
Sorry to come in. I just want to, that was very interesting. The Ewing sarcoma, that was quite eye-opener to me. You resected it and then you irradiated it, is it?
Yes, so that is.
Tell me more about it. It's not my field actually. Could you tell me more about that, please?
So that is something that we call as extracorporeal radiotherapy, or EC in short. This is something that the Birmingham group has been doing for quite some time now.
Okay.
And we in India are doing for maybe at least 15 years, if not more. So what you do is you resect the tumor. Let me see if I can share that again for you. Yeah.
Yeah, this is the one. Yeah.
So we can see that the proximal tibia here was, the tumor was involving the metadiaphyseal area and the epiphysis was spared. We can see even in the MRI that the epiphysis is spared and the growth plate is limiting the tumor. And what we have to do here, because this was an intercalary resection which was not involving the joint, we made two osteotomies, one below the tumor and the one just above the tumor. And this is how we did. In those times, we did not have intraoperative computer navigation. Now we do this with intraoperative computer navigation. You place a K-wire and just cut along the physis, and you know you've got a wide margin. And this is what I meant when I said we have to go for a wide excision. So this is how you do. You send this specimen for radiation. This we can see this bone after being the soft tissue, all of the soft tissue having been removed. This is the bone. You do all this separate from the table so that there is no tumor contamination. You wrap it up in sterile packing and then with wet gauzes, and you send for radiotherapy. They give about 50 grays of radiation in about 15 minutes. Send the specimen back to you in OT, and you can now use this as an allograft. It is just like any dead piece of bone, just like an irradiated allograft. And the beauty is that it just fits the defect that you want to be reconstruct, because it was the bone that was taken. Sorry. So that's what you mean by extracorporeal radiation and reimplantation. And this, of course, you are doing a muscle flap over that. And this is the final construct. You can see the bone has healed beautifully. We have placed an intramedullary fibula here, and the good part is that this being a biological reconstruction, we do not have to wait for the patient does not require revision surgeries as they would do in a mega prosthesis. And even after say 8 years, the reconstruction is pretty solid. And this patient is now not just cured, but also has a permanent reconstruction of the leg. So that is the beauty of this reconstruction. People are now also using pasteurization and even cryotherapy for this extracorporeal treatment and reimplantation. Yeah, so this is quite exciting.
Very good. Thank you. Really great.
So, Dr. Santosh, I guess that is all there is for today.
Yes, yes, yes. It's very fine and it is very informative as well. And I think the next will be more interesting and interactive.
Yeah, so the next one is going to be on X-rays, and I think that is again extremely useful for all orthopedic surgeons. How can we just put an X-ray on a view box and say whether it is malignant or benign with some degree of confidence? Obviously, it will not be possible all the time to accurately diagnose, but more than 80 or 90% of cases can be designated as benign or malignant just from an X-ray. And that is what is going to be covered in the next webinar. I think we'll have it circulated well in time so that more and more people can join us.
Thank you. Thank you.
Thank you. Thanks, Akshay.
All the delegates and all the seniors and colleagues with Dr. Akshay. Thank you so much. We will next meet on the next month.
Yeah. Thank you. Thank you, Dr. Santosh, for the opportunity. Thank you, everyone, for listening.
Thanks, Akshay. Thanks a lot.